Thanks, Susan, and thanks to all of you for joining us today. It's really such a pleasure to have a chance to talk to you about what is the newest therapy, the newest FDA-approved therapy for metastatic melanoma, and something that I've been working on now for many, many years. So to see it come to fruition, and some faces in the room that have even had some discussions about this with me. So we will talk about TILs, or tumor-infiltrating lymphocytes, but to set the stage for that, I think it's important to understand where we've come and where we were maybe a decade and a half ago to treat metastatic melanoma, when all of the prevention strategies we've heard about, we progressed past that, we progressed past this early treatment stage where melanoma's in a lymph node, and now we're stuck with melanoma that has spread in the body. And now what do we do? So if you had come to one of our clinics, 15 years ago, we did not have any of the immunotherapy strategies that you've heard about today. We did not have the targeted therapy medicines that we talk about today. And we were stuck in an era where we used chemotherapy for this disease. And that was one of two medicines, but predominantly a medicine called the carbazine, which you will very rarely ever hear us mention in our clinic anymore, which is a wonderful step forward for us. And so if you had come to our clinic at that time and asked us, doctor, how long could I expect to live? The average was about 6 months. And that was the best that we could do. And now with the improvements that I just talked about, immunotherapy, targeted therapy strategies, but particularly this combination of ipilimumab plus nivolumab, if you are newly diagnosed with metastatic melanoma, and we offer you this combination of ipilimumab plus nivolumab, the average survival went from 6 months to over 5 years with one drug combination approval. And that is truly incredible progress in a decade and a half. But I'm going to make the argument that that is just not enough. Right? So when we look at these curves, these are what we call overall survival curves, and anything under those lines, right? So that red line here is that red combination of ipilimumab plus nivolumab. Anything under those lines are patients doing really, really well, surviving, doing well from their melanoma. But those lines aren't flat, and there's still areas above those lines where we have patients who aren't surviving their melanoma. And that's what I'm really going to talk about today, is what do we do for all of these patients? When that treatment does not work, where do we go? And this, to me, is where TIL therapy fits in. So TIL stands for tumor-infiltrating lymphocyte. And that's a big fancy word to say when I take out a tumor, I find these lymphocytes or immune cells in that tumor, shown here in purple. And in theory, those lymphocytes or immune cells have the ability to treat or even kill cancer. But for some reason, if I take out a tumor in a patient, they aren't working. And there's a variety of reasons why that might be true. But one of the reasons is there's probably not nearly enough of them. And so the idea behind TIL therapy is essentially to take out a tumor, find those lymphocytes, expand them into the many billions of cells, and then give them back to a patient. And many of you have probably heard of something called CAR T-cell therapy or even TCR therapy. And it's a slightly different approach where we take out naive T cells from the blood, and then we put on a receptor that tells those cells to go after cancer. And that is certainly something we're working on. But as of yet, we have yet to find a CAR T-cell that does much for melanoma. So that strategy is certainly something we're working on, but that's not yet ready for prime time. But TILs, they're here and they're ready. So what this process looks like, again, patient undergoes a surgery. We take out a piece of tumor that's somewhere between 1.5 centimeters and about 4 centimeters of tumor. Dr. Karani does a wonderful surgery and then chops up that tumor into little pieces. We find those immune cells in the tumor. We send this at present off to one of several companies, but the company with the FDA-approved drug is a company called Iovance. We ship this off to them. They basically separate out the tumor cells from the immune cells, grow up the immune cells in many, many big petri dishes, test them to make sure that they're safe and pure and not infected and all of those good things, and then put them in a bag, freeze them, and ship them back to us. Once we get those shipped cells back to us, We take a patient, we say, great, we are ready to go. I've got my frozen bag of cells in my hand, and we start this process. And that process looks like an initial 5 days of chemotherapy. And that chemotherapy doesn't treat your melanoma. What it does is gets rid of all the immune cells and all the other competing things that would make the TILs, the good cells that I'm going to give back, not work for you. Right? They get rid of the competition. And then we give the immune cells, the TILs, followed by a medicine that is called high-dose IL-2. And you actually heard Susan mention high-dose IL-2 briefly. This was a treatment we used to use in and of itself for melanoma, and it was a really tough treatment. The amount that we give to stimulate the TILs is a much lower number of doses. But it is critical, at least at this point, to make those TILs healthy, happy, take hold in the body, and actually start to expand on their own and trigger a big immune response in the body where those cells can specifically go after your particular tumor. This all takes place in the hospital. Patients are in the hospital somewhere around 2 weeks, around that period of time, while getting the chemotherapy, the cells, the IL-2, and then recovering from side effects of all of those things. And we'll talk through a little bit of each of those. But I think the first question is, how well does this actually work? So these are big fancy plots that we use as oncologists all the time, but essentially you see a big flat line down the middle. If anything is going downward from that line, that means tumors have shrunk. And anything that's going upward from that line means tumors are growing. So I think just on a large level here, you can see that most of the lines are going downwards, and that's a very good thing for a drug. Right? That means that drug is working and melanoma is shrinking. You see this sort of faint gray line at that 30% cutoff. That is the magical number that as oncologists we use to say, yes, we've seen real tumor shrinkage. So when we say partial response, that is 30% shrinkage or more of a tumor. So if we look at the numbers from the what's called C-14401 trial, but the trial that led to the approval of this drug, like Lifileucel, or its trade name is Amtagvi, right? 6% of the patients had their tumors go completely away. 31% of the patients had their tumors shrink or go completely away. But I think really promisingly, in addition to those numbers, which are good but not good enough, is that nearly 80% of our patients had their tumors stabilized. And while I wish that that was 80% of our patients that had their tumor shrink or go completely away, if a tumor stabilizes and a patient is doing well, that is a big, gigantic win for us when patients have progressed on other standard therapies. And prior to this, and quite frankly, other than this, we have no other drugs that we know of today in 2024 that have had anywhere close to this type of result for melanoma that has progressed on standard immunotherapy. And I think equally promising is that this is a one-time treatment. So we typically think of treatments that you get every 3 weeks or every 4 weeks or every 6 weeks, right? Chemotherapy, immunotherapy, targeted therapy that our patients take every single day, right? This is one big, tough several weeks or months, but then that treatment is ongoing for weeks, months, and potentially even many, many years. And that is the true promise of a cell therapy approach. This is a one-time treatment. And in this trial, of the patients whose tumors shrunk and responded, 42% of those patients had not needed any additional treatment for their melanoma at 18 months. And that is the published data. We now have updates at 2 years and beyond. And we actually all, anyone who treats melanoma in the room know of patients who are 10 plus years out that have not needed any treatment. So again, a really tough several weeks. It is a big treatment. It is not a small undertaking, but the potential at a one and done type of approach for melanoma. And this is why we are so excited about it. So what are the side effects? Why is this such a tough couple of weeks? So a lot of the side effects are related to one of two things. So one is the chemotherapy. So the chemotherapy is needed, again, to wipe out all the competition, but chemotherapy comes with chemotherapy side effects. So hair loss, the potential for nausea and vomiting, although we now have very, very good medicines that help to prevent that, let alone treat it, but actually prevent the nausea altogether. But the biggest risk of the chemotherapy are the risk of getting an infection because we are knocking down your immune system, and the risk of bleeding because a lot of the clotting cells in your blood will also go away as a side effect. The other big risk is actually that IL-2. So the cells themselves actually have very little risk, but the IL-2 medicine is really tough, right? It causes high fevers and shaking chills. I always tell my patients, if you've ever had a terrible flu or COVID, right, you had high fevers and shaking chills, that actually was your body making IL-2 to try to stimulate your immune system to treat that virus. We give that medicine in higher doses. So in addition to the fevers, the shaking chills, IL-2 is a medicine that causes the fluid to sort of leak out of the bloodstream. So the blood pressure can get low. We can have tough effects on the kidneys and other organs. This is something we monitor very, very, very closely. But I think one of the most important things to know, and can you see the pointer? One of the most important things to see here is this huge spike in side effects, right? The rate is certainly high, but if you look, it is almost completely gone after day 14, right? Day 14 or day 15. And that is the time that you are in the hospital being monitored very closely under our care. And we have medicines that treat a lot of these side effects. So any of you have heard me talk about this. I always say this is a really big hammer, but it's a really big hammer for a big nail, right? This challenge of melanoma that has progressed on standard therapies is a big challenge. This is a big hammer to treat that big nail, and it is not easy, and not every patient is appropriate, and we'll talk about that. But this is one of the most exciting things that has happened to us in the melanoma field in many, many years. There was a second study that studied TIL cells, slightly different, not made by this company, but essentially the same process, and actually compared it to ipilimumab directly for patients who had had only single drug PD-1. And what you can see here is if we look at TILs in yellow versus ipilimumab, the progression-free survival, meaning how long patients did before their melanoma started to grow, was significantly better for TIL. The response rate in these patients, so shrinkage of tumor or tumor going completely away, was actually as high as 49%. Why is that different from that 31%? Well, probably one of the biggest reasons was that these patients only had one treatment before. Versus that C14401 trial, the lifileucel trial, many of those patients, including some of my own, were on third, fourth, fifth, sixth, seventh, 10th line of treatment because it took that long to get onto the trial. And so one of the things that we've learned from these data is how important it is for us to take our patients, recognize that progression early and get them right to TILs when it's appropriate, right? And again, not appropriate for everyone, but not waiting and trying 5 or 6 different things before we go to this treatment, because this treatment needs to be done when patients are well and healthy and fit, and optimally right after progression on a first-line treatment. And one of the things that came out of this study was data from Dr. Hannon and his colleagues that really looked at, they did something really smart. They said, yep, it's going to be a really tough 2 to 4 or 6 weeks of this treatment. But what do patients look like 6 months later, right? Have they recovered? Do they feel well? And they looked at health-related quality of life and various metrics, global quality of life, physical functioning, emotional functioning, fatigue, pain, all kinds of other health-related quality of life, and showed that these patients who got TILs actually did better than patients 6 months out, than patients who had gotten a different type of immunotherapy after progressing on a frontline immunotherapy, our first immunotherapy treatment. And again, what that tells me is, yep, we might be in for a tough month together, but once we get through that, right, the future is really quite bright for these patients. So all of that being said, this finally came to fruition. This treatment started to be developed in the late 1980s at the National Cancer Institute. It took 40 years for us to get this to our clinics, but it is here. February 16th, this was approved by the FDA. And we had the privilege and the honor of treating the first patient in the world after this drug was approved. So this approval came February 16th. That was a Friday afternoon. Many of our doctors were actually on tumor board with me when this approval came. I said, sorry, got to go. We got to arrange this. And less than 12 business hours later, Dr. Karani had the first patient in the world in the operating room. That middle picture was our team taking out that first tumor. And that far picture on the right was us on April 4th infusing the first patient in the world with lifileucel. So who is this right for? So right now, and we're hoping this is going to continue to evolve and expand, but right now, right, this is for patients with non-uveal melanoma. And Dr. Shrustari is going to talk about uveal melanoma and some work even with TILs that he and I have done, but predominantly he has done with TILs for uveal melanoma. But patients with cutaneous melanoma, acral, mucosal, and melanoma of unknown primary are all considered eligible for TILs. Patients who've had their tumor grow despite treatment with at least one immunotherapy regimen that contained a PD-1 medicine, so that's Opdivo, or Keytruda, nivolumab, or pembrolizumab. And if a patient has a BRAF mutation, at this point still need to have had targeted therapy medicine as well. Patients with relatively slow growing disease. So these cells, they have to grow, and it takes about 5 weeks for them to do. So if a patient has really rapidly growing disease, this might not be the right treatment because that 5 weeks is actually a really long time to wait after the surgery to go on to a next treatment. Though we can give some what we call bridging treatments during that time, really rapidly progressive diseases, this is probably not the right next step. You have to actually have enough tumor for us to take out to make these cells, and then another site of disease to trigger the cells to actually work. Good performance status. So what do I mean by that? Patients who are able to, do a full walk around the block, right? Go to work, although you don't necessarily have to be working, but would have the capability to do that. Self-care, light housework, right? This is a tough treatment, as I said, and you need to really be able to be fit enough to withstand it safely. Normal or near normal heart, kidney, lung, and liver function, because all of these medicines can affect all of those organ systems. We need to make sure that you're well enough to withstand it. As of right now, this treatment is not appropriate for patients who have melanoma that is actively growing in the brain. We're going to talk about this in just a second, but we are studying how to make this safer for patients who have melanoma that is growing in the brain. Prior treated stable brain metastasis, totally fine, totally appropriate, and those patients were included in this clinical trial. But active melanoma growing in the brain, not quite ready for prime time yet. Not on steroids because steroids actually inactivate the TILs. And so we can be on replacement steroids for our patients who have had side effects of immunotherapy that resulted in adrenal glands or the pituitary gland not working. So low doses of hydrocortisone are okay, but high doses of steroids to treat side effects of immunotherapy, et cetera, would counteract the TILs. And so right now that isn't something that we can do. And then no active infections because of the need for the chemotherapy. So how do patients get access to this? I'm asked this frequently. And certainly we have the privilege here of being what is called an authorized treatment center. We are the only authorized treatment center in Northern California. And one of the very few in the Pacific Northwest. But there are others out there for anyone live streaming online from sites all over. There is a map of where you could find an authorized treatment center closer to home. Up-to-date testing, which we can do when you come to our clinic. And so what I wanted to tackle with just the last couple of minutes is, where are we going with this, right? So, we ask questions all the time. great, we've made this huge progress. We just got this drug approved. None of us are resting on our laurels saying that 31% response rate is good enough, right? Where are we going now? Now we have a drug. How do we make it better, right? And these trials were actually already in the work before we even had the approved drug. So the first is this question, up to 70% of our patients with advanced melanoma will develop disease in the brain itself. So we need to find a way to let cell therapy help these patients. And so this is a trial that I helped to develop when I was at Memorial Sloan Kettering. It was taken over by Dr. Shushari, and that he and I have co-managed together for now the last 2 years. And this does bring lifileucel to patients with active brain metastases. This is a very small trial where we were just trying to make sure we could find a safe way to do this. So not to study the efficacy yet, but just try to find a regimen that was safe. And this required us to lower the dose of the chemotherapy to try to prevent bleeding. It involved using prevention of seizure medicines because that IL-2 can increase the risk of seizures, particularly for patients who have disease in the brain. And this trial was 10 patients. We're delighted to announce that all 10 patients are now through the trial. And I'm actually going to be presenting the results of this trial in a month or so at the Society for Melanoma Research Congress. But equally beneficial from this is that each of those patients offered us tissue and blood that we are bringing back to my lab to study to understand why this may or may not be working for particular patients and how we can make it better. We're also looking forward to hopefully in the coming year or so an expansion of this trial to start to study the efficacy of this treatment for patients with brain metastasis. So we were just talking about completing this trial for patients with active brain metastasis and the hope that we will have data for the first 10 patients presented at the end of October. And then hopefully an expansion of this trial to begin to look at efficacy in the brain in the foreseeable future. And that is something, a trial that we will bring here to Stanford as well as at Memorial Sloan Kettering. Two additional trials that I'd like to mention. Again, I think on this theme of what we have, we're so thrilled that we now have a cellular therapy option for our patients, and we still know that we have a very long ways to go. And so the first is this trial of LYL845, which is a new modification on TIL. And the big difference here is essentially that we just grow the cells in something different. And the idea of that is that the cells, when grown in this maybe different or potentially better media, could be more have more killing ability and also more ability to trigger a long-term durable response, what we call a memory T-cell response. And so we are excited about this trial. We are open and accruing patients here at Stanford on this trial and actively treating patients here. And with the goal in the foreseeable future, actually, that this, once it passes the initial safety phase of this trial, is going to actually expand to include patients with both lung cancer and colon cancer. So as we've seen with the approval of checkpoint inhibitors, right, they were approved first in melanoma. We saw ipilimumab, followed then by the PD-1 drugs, nivolumab and pembrolizumab. They were approved in melanoma, and then all of our colleagues across many, many cancer disciplines started using these medicines to great effect. That is the hope for TILs, right? We approved it first in melanoma, and the hope is that we can begin to expand this to many other types of cancer. The second trial that I'd like to mention, which we are also open and accruing for here at Stanford, that I have led, been part of the leadership team of nationally, is this trial of OBX115. And this is a really fancy diagram, but essentially what this diagram says is when we do that surgery and we take the cells out of a patient, we have engineered on the ability for cells to make a molecule that's like IL-2. And the cells make that molecule is called IL-15, and we can turn it on and off. This sounds like next generation sci-fi stuff. Even when we were first talking about it, it felt like next generation sci-fi stuff to me. But we actually have the ability to turn these cells on and off when we give the patient a drug. And this potentially eliminates the need for us to give that medicine called IL-2 to patients. This could make this much, much safer, accessible to more patients, older patients, patients whose lungs or hearts are not as well, as perfectly, as perfect in perfect condition. And so we are really excited about this trial. We have patients active and accruing and being treated on this trial as well at Stanford. And one of the other advantages to this trial is it is actually using a lower dose of chemotherapy in the preparative regimen. This trial is actually now nationally accruing patients with lung cancer as well as here at Stanford as well. So again, this idea that what we start in melanoma really begins to affect many other cancers in a very, very positive way. So with that, I will wrap up and conclusion. So TIL therapy is finally here for advanced melanoma after 35 or 40 years of working very hard to bring it to patients. This offers a one-time treatment option for patients. While the side effects are significant during those several weeks of treatment, they are short-lived. We are getting much, much better at managing them as we treat more and more patients and actually are helping to prevent more of these side effects now that we know what they are and when they occur. And the data from Dr. Hannon's trial really tells us that the long-term quality of life for patients who get this treatment is excellent. And lifileucel and TIL cell therapy clinical trial options are available in melanoma and now beyond melanoma. And really encourage people to, discuss this with their team if patients do have advanced melanoma. So I'll say some really important thank yous, first and foremost, to our patients and their caregivers and their loved ones that make all of this work not only possible, but worth it for us as well. It truly brings us so much joy to see so many of you in the room and online. To our fabulous melanoma dream team, that you have heard from today, to our larger melanoma dream team, our nurse coordinators who are holding it down in the back, our research team, my research lab that is working on how to understand these TILs and how to make them better. The team at Memorial Sloan Kettering, which includes Dr. Shushari and his colleagues, where I first worked on this treatment and are now they have continued this with great success. My mentors who moved from Memorial Sloan Kettering to Cornell, and all of the funding agencies for all of the research that I do in this area. And with that, I will say thanks.